DIY for glaucoma procedures. Practice makes a doctor perfect. Glaucoma is the leading cause of irreversible blindness in the world. By 2040, around 112 million people in the world will be affected by glaucoma. But are we having enough glaucoma specialists to tackle this burden? The number of ophthalmologists worldwide is estimated to be 2 million, but many of them do not operate or do only a few number of surgeries. Welcome to the world of glaucoma fellows. After completing clinics, enthusiastic glaucoma fellows walk towards the wet lab, chattering away happily, discussing what to practice on the goat or human eye. To their disappointment, they find that there are no goat eyeballs to practice that day. So, no wet lab practice, but tomorrow is the operating room posting. Necessity is the mother of invention, or rather innovation in our case. An idea pops up. Here begins the journey for the do-it-yourself glaucoma project. First, we had to create an alternative to goat or human eyeballs for wet lab practice. We thought of silicone eyeballs. They are a good, reusable option, but a bit costly and difficult to find and maintain. So we thought of making our own practice eyeball. We took a pair of gloves, cut out the finger, and filled one finger with water, another with leftover viscoelastic, and the third with toothpaste. We tied them up with an elastic band of used masks. Then we mounted it on a used keratome with its cover and used its handle to hang the eyeball on the slit lamp. Let's see what problems got solved. We tried measurement of IOP by eye keratometer, tonopen, applanation tonometer, central corneal thickness by ultrasound pachymetry. One can hold it like an eyeball vertically and practice as in a human eye. All of our nurses, students, and consultants tried it and liked it. But we wanted to explore more possibilities. So we thought, can we mimic surgical procedures? Then we tried doing AC decompression using a 26-gauge needle. We tested with water, but it collapsed once it was punctured. Next, we filled the glove finger with viscoelastic because it was transparent and at the same time more viscous. Next was bleb needling, for which we used red toothpaste to get the red glow and better visualization. We marked the limbus and scleral flap on the model eyeball and utilized a 26-gauge needle to practice bleb needling. Then we thought, what about lasers? So we created two models. First, we used a suture sponge with pre-placed sutures on it in radial fashion mounted on a used keratome for practicing laser suture lysis. This served two purposes, practicing suture placement, and second, of the laser suture lysis using double frequency Nd:YAG laser. We made another eyeball for laser peripheral iridotomy, for which we used 1. Old trial lenses, ones with the glass to mimic the cornea and ones without the glass to give a little bit of depth to mimic the anterior chamber. 2. A carbon paper to mimic the iris. 3. A waste bottle cap, preferably red, which acted as the posterior segment and the red contour mimicked the fundal glow. 4. Micropore to tie it all up together. 5. Used keratome to mount on the laser slit lamp. We finally tried working on the plan for which all started, to learn to raise the flap. So, we took the waste sponge, marked the specifications of the flap with calipers, and raised the flap with a blade. And sutured the flap. The sponge gave the feeling of the sclera indeed. Finally, the happy moment arrived. Having practiced almost all the instruments, flap raising, suturing, and laser suture lysis, the fellows felt more confident in the OR and in the clinics. This video shows that where there is a will, there is a way, and nothing can stop if a student wants to learn and a teacher wants to teach. Thank you.